would like to call this meeting back to order. This is the Health and Human Services Finance and Policy Committee meeting, and we are resuming our agenda on Senator Klein's bill, Senate File 3859. Senator Klein.
Thank you, Chair Wiklund and committee. Thank you for hearing Senate File 3859. This is the third committee stop for the bill, and I do have an amendment once I get through describing the bill. This bill would establish a Minnesota Science-Based Advisory Vaccine Council. It would have 14 members, trusted scientists, clinicians, and public health leaders with knowledge of and background in vaccines and immunizations. It would be tasked with developing a recommended schedule of vaccines, advising the Commissioner of Health on school and high school education immunization requirements, and consider peer-reviewed scientific studies. It would also require immunizations that are recommended by the American Academy of Pediatrics to be covered by health insurers operating in Minnesota. It may interest the committee to learn that we actually had a committee just like the one that I'm proposing in law today. There was a Minnesota Immunization Practices Advisory Committee in the state from 1991 through 2019, doing precisely what I'm envisioning this council to do. That body was disbanded in favor of the Federal Advisory Committee on Immunization Practices in 2019, but the need returns since the federal body has been replaced with members who are advising things that are not supported by most medical professional societies. So that's what the bill does, Madam Chair. It is both establishing this commission to advise us for best practices on vaccinations and also requiring insurance to cover those recommended vaccinations. It should be noted that this bill does not require any Minnesotan to take any vaccine or medication that they choose not to. It simply uses our best science that we have available, Mayo Clinic, University of Minnesota, elsewhere, to advise on best practices supported by science. And with that, Madam Chair, I do have an amendment, and I can discuss it if one of your members offers it.
Senator Klein, is that, let's see, is it the A12?
The A12.
So Senator Boldon offers the A12 amendment. Can you describe the amendment, please?
Yes, Madam Chair, in a previous committee, at the Commerce Committee, actually, where this bill originated, I put in defrayal language, basically saying if we're going to mandate that these vaccines are covered by the public health plans and private health plans, that if that results in an increase in premiums for Minnesotans, the state would defray that increase through tax expenditures. The chair of the HHS committee and myself have a philosophical disagreement on defrayal, and in the interest of moving this bill forward, I'm removing that language at this time.
Thank you. Members, any questions about the amendment or comments? I'll just say I have supported this bill, and then I would prefer that it go forward with the coverage, you know, that it's stated, you know, that it is required that they cover these preventative services. So I would prefer that it goes forward without the defrayal language. Any other questions or comments? Seeing none, Senator Boldon moves the A12 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and the A12 amendment is adopted. Senator Klein, I don't have anybody listed as testifying. Members, do you have questions or comments about the bill? Senator Abeler.
I'm just trying to catch up with what got taken out, but it doesn't matter. I think it's the same general idea. It's just a question. You missed a nice discussion this morning, but I'm not going to rehash this morning's discussion for you, and I'm glad this doesn't make anybody do anything against their will. But as these committees look at what to do, what makes sense to add or subtract from the list, can you tell me the latest on how they consider contraindications and side effects that seem to be, you know, nothing? And I'll give you, probably know a hint of what I'm asking, because it seems in the discussion of this, even talking to Mr. Osterholm about the COVID vaccine, he said it's as safe as aspirin, and I don't think people think that anymore. So when they consider what's a good or bad idea, what consideration do they give to that? And I'm not sure if they do. So can you comment about that, please?
Senator Klein.
Madam Chair, Senator Abeler. So I myself am not a vaccine expert. Although I am a physician, I don't claim to have full knowledge of the body of literature, but that would be the charge of the health practitioners, physicians, public health expert, nurses, et cetera, assigned to this 14-body group, that they would review the literature published in established medical journals, and then they would give us their best advice based on that review.
Senator Abeler.
Well, thank you. I appreciate your confidence. I wish that were more true. There's just so many instances where, well, I'm not going to spend much time on this, Madam Chair, but here we are on 2 of a series of 3 of these topics that we've discussed in the past, and I appreciate the collegiality of my good colleague there, but I wish they would take into consideration the reports of people. I wish that the doctors would report to VAERS like they're supposed to. They say less than 1% report, so then VAERS becomes an irrelevant thing, and then they say, well, you were lying, and it's actually nurses and doctors who report this. So I'm not confident. And so back to my position on this, I'm not anti-vax, I'm pro-informed choice, consent. And it seems like as you add to the list, which is very large in the 2 and 4 month list, that they could do better. And just, so that's all. And I wish maybe in their report, we talked this morning about that there were people wishing to get an exemption from a vaccine that they clearly were not able to take. Senator Liskey was talking about that in his own situation. 3 doctors said he shouldn't take the COVID vaccine because of an earlier reaction to a MMR when he was a kid, or he went lame for a month. So, and they said, we shouldn't take it. Will you give me a note? No. So I just, as we go forward here, I just hope the intellectual honesty that you bring to this with your good intent could follow into that. So I guess it's just a comment, Madam Chair, so thank you.
Any thoughts, Senator Klein, or it wasn't really a question? So.
No, Madam Chair.
Okay. Any other questions? Senator Radke.
Thank you, Madam Chair. And, you know, I don't really have a lot on this. It's just that I don't really see what an advisory council is going to do to help the situation. We had a long conversation this morning, and it has to do with, in the end, a relationship between the patient and, in a lot of cases, it's the parents of these young children and the doctors. And there has to be that relationship, and there has to be the confidence in the expert, which would, you know, they're going to the doctor to get the information they want. And there's got to be a level of comfort. And this morning we were taking a look at something that was mandating this. I don't know how the advisory council is going to help close that gap either. It's just another, you know, the advisory council is going to look at what vaccines should be offered or available. But in the end, it's getting the comfort level to the level of the parents. And, you know, I still think that's the $64 question is how do we get to that so that that knowledge is shared. And in some cases, we've got people that, you know, aren't able to have the vaccine because of whatever's going on. Others that may look at it but are scared, and, you know, vice versa. And, you know, it's just trying to close that gap. And I don't know where we're going with this. It's going to help do that because I don't think we've accomplished anything yet today on this, and just looking for the help.
Senator Klein.
Madam Chair, so this bill is silent on what any individual parent chooses to offer to their children. But if you are a parent in Minnesota who says, I would like to base my decision on the best evidence that published medical journals and medical science has to offer today, this bill would give you that option. And I can tell you as a practicing physician, I don't have the time or the bandwidth or really the intelligence to read the 480 published reports this year on vaccines or last year. But this body would, and they would then discuss it in forum and come to their very best recommendations. And then it would be available on one white sheet of paper for a practicing physician like me to give to a parent and say, this is, what this august body decided medical science tells you is the best advice for you in this moment. And then if that patient or that family or that parent chooses to go to VAERS and look at those reports, or chooses to go to the Federal Commission, which has been replaced by some different personalities, then that would certainly be their choice. But this would be this option for Minnesotans.
Thank you. Senator Etke, any?
Thank you, Madam Chair. That's all. Thank you.
Okay. Any other member questions or comments? Okay. Well, thank you, Senator Klein. I mean, I think we've seen over the past year some changes and kind of disruption to the pattern that we had been seeing as far as vaccine approvals, and even yesterday, some court rulings on, that affect the people who make up that federal board or commission. So it seems like this bill is a prudent way for us as a state to bring more information forward and have a way to have a state group that is focused on this issue and focused on how to come forward with the best advice that we can. So I appreciate your bringing it forward. This bill is waiting for a fiscal note, I think, but we are planning to send this to the Finance Committee, and they will have to deal with getting the fiscal note information. And so we will pass it out of the committee today. We're not in a typical budget year when we have budget targets that we're working on by committee. So I will move this along, and then the financial implications will have to be reviewed by the Finance Committee. Any other questions, members? Then I guess I would make a motion. Senator Boldon moves that Senate File 3859 as amended be recommended to pass.
Madam Chair, could we request a roll call?
Yes. Senator Cran requested a roll call. Roll call granted. I will restate the motion. Senator Boldon moves that Senate File 3859 as amended be recommended to pass and be referred to the Committee on Finance. And Ms. Ryan will take the roll.
Chair Wiklund,
Yes.
Vice Chair Mann,
Yes.
Lee Dutke,
No.
Senator Abeler, Senator Boldon,
Aye.
Senator Fate, Senator Karan,
No.
Senator Kupek. Yes. Senator Liskey,
No.
Senator Port.
Yes.
There being 5 yes and 4 no, the motion does prevail, and Senate File 3859 as amended is passed and referred to the Committee on Finance.
Thank you, Madam Chair.
Thank you. And now we will move to Senate File 4416.
Senator Wiklund. I believe you have an A1 amendment. Would you like to speak to that first?
Yes, that was a technical amendment to get the bill the way that the department had intended to bring it forward. I'd like to move the A1 amendment.
Senator Wiklund moves the A1 author's amendment. All those in favor say aye. Aye. All those opposed say nay. The amendment is adopted. Senator Wiklund, to your bill as amended.
Thank you. Senate File 4416 is a bill that's brought forward by the Department of Health. I'll just give a brief overview of what the proposal does, and then we'll have a testifier from the Department of Health. What this bill does is to ensure that Minnesota's immunization requirements remain clear, stable, and evidence-based. It updates statute to preserve Minnesota's reliance on national medical guidance while allowing flexibility if recommendations diverge. And the commissioner remains constrained by additional statutory criteria when adding or removing vaccine requirements. And I'm not sure if the department's, I will turn it over to my testifier.
Welcome to the committee. Please introduce yourself and present your testimony.
Thank you. Chair, members of the committee, I'm Elizabeth Perilla, manager of the Vaccine Preventable Disease section at the Minnesota Department of Health. Schools, childcare providers, healthcare professionals, and families are currently facing confusion about immunization requirements. Minnesota's law requires that 3 organizations, the Centers for Disease Control and Prevention's Advisory Committee on Immunization Practices, or ACIP, the American Academy of Pediatrics, or AAP, and the American Academy of Family Physicians, AAFP, all agree before the commissioner can begin the rulemaking process to add or remove an immunization requirement. Recently, the federal CDC schedule diverged from the AAP and AAFP schedules. Under current law, that disagreement means the commissioner may not be able to act, even when action may be needed for public safety. Additionally, Minnesota rules define the term medically acceptable standards simply by broad reference to ACIP, which is now creating confusion around dose and timing guidance. We propose 2 targeted fixes. First, update the statutes so the commissioner considers recommendations from all 3 organizations rather than requiring consensus before starting rulemaking. To be clear, adding or removing a vaccine still requires a rigorous, transparent rulemaking process with public input and strict criteria around disease burden, vaccine safety and effectiveness, and cost effectiveness. This change simply removes a roadblock that would otherwise prevent that process from moving forward at all. Second, replace the current rules-based definition of medically acceptable standards with a more robust statutory definition. This term defines important details like the number and timing of doses for vaccines that are already required. This new definition would allow the commissioner to consider current medical guidance from ACIP and the professional organizations to provide details on needed doses and timing. Together, these changes ensure the commissioner can provide clear, timely guidance to schools, childcare, healthcare providers, and parents. I want to be very clear about what this proposal does and does not do. These changes are intended to provide clarification to the existing vaccine requirements for enrollment in schools, childcare, and higher education. The current immunization requirements would stay the same. Likewise, this proposal does not change or limit parents' existing rights to claim exemptions from immunization requirements. Parents can still claim medical and non-medical or conscientious exemptions. Thank you for your time and consideration.
Thank you for your testimony. And next we have on Zoom, Lisa Matson. Please turn on your camera, unmute yourself, introduce yourself, and proceed.
Good evening, Madam Chair and members. My name is Dr. Lisa Matson. I have the honor of serving as president of the Minnesota Medical Association. I'm a Mayo-trained retired OBGYN who's still passionate about ensuring high-quality healthcare for all the people in our communities. Today, I want to thank you for the opportunity to testify in support of Senate File 4416. The medical consensus is still that vaccines do in fact remain one of the safest, most effective, and most cost-efficient tools we have in modern medicine. As I have acknowledged in previous testimony, nothing is risk-free, and everyone agrees that providers should always review risks with patients and parents. This bill helps ensure that Minnesota's immunization policies are grounded in the best available medical science. Specifically, it clarifies that medically acceptable standards for immunizations are based on the schedule determined by the Commissioner of Health and informed by recommendations from leading national medical and public health experts such as the American College of Physicians, the American Academy of Pediatrics, the American Public Health Association, and the American Academy of Family Physicians. Minnesota is also uniquely qualified to determine the appropriate use of vaccines, given that we are home to the Mayo Clinic and the University of Minnesota with its Center for Infectious Disease Research and Policy and the Vaccine Integrity Project. These organizations conduct rigorous scientific and statistical reviews and rely on decades of research and real-world data when developing immunization recommendations. Aligning Minnesota statutes with these evidence-based standards helps ensure that our state's vaccination policies remain current, medically sound, and responsive to evolving public health needs. This is particularly important at a time when the vaccination rates in Minnesota have declined in recent years. When immunization rates fall, communities become more vulnerable to outbreaks of preventable diseases. Maintaining clear, science-based vaccination standards helps protect not only those who receive vaccines, but also infants, older adults, and individuals who are immunocompromised, like those with cancer and autoimmune diseases. I urge you to support Senate File 4416. I thank you for your time, and I'm happy to answer any questions you may have.
Thank you for your testimony. Senator Wiklund, any other comments before we move to discussion? No. Members, just for awareness, the plan for this bill is to vote it out to Ed Policy. Senator Abeler.
Thank you. Madam Chair, I have a question for the good doctor who just testified, if she's willing to take a question. Anyway, so I'm sorry I forgot your name, but Dr.
Lisa Matson.
Oh, yeah, thank you, Dr. Matson. So you were listening probably in the previous testimony where I asked Dr. Klein about the contraindications and side effects. Can you tell me, in your view, you seem like you know a lot about this, and I respect you for that. So can you tell me in the discussions that you must have behind the scenes, what input you put about side effects that have been reported?
Dr. Matson.
As far as, thank you, Madam Chair. As far as input, are you talking about what I tell patients?
Senator Abeler.
Well, I don't know. I mean, you're coming here as an expert testifying that this is a great idea. I'll just make my concerns clear. This morning I talked about a Somali woman who I had met, and she had 4 kids, and over the course of time, the first one got injections and became nonverbal. And the doctor said, not to worry, it's all fine. Dr. Klein referenced that. I just want a single-page sheet that tells me what's a good idea, and that the doctors are trained and urged, it seems like, to tell people these are safe and effective. And so the doctor says, well, I'm sorry, or these things happen, but it wasn't the vaccine, or not to worry. And the child remains very challenged. And so by faith, she took the second child in for that series of whatever immunizations, and that child became nonverbal. At that point, she decided on her own, I think we've had enough immunizations in our family. And I know that just talking to some of my Somali friends, they call this the shot that makes the kids not talk. And so I just wonder in the deliberations that go through what you know, and maybe on behalf of the Department of Health, how they take that into consideration, because it seems like they do not. So how can you reassure me that these are taken into consideration? Like, that maybe you're the wrong person to ask. I just thought you were handy and would know a lot about that.
Dr. Matson.
I'll see if I can answer as best I can. I can't speak to this particular incident because it's very difficult to determine cause and effect. Certainly with 2 children who had nonverbal issues after a shot, it's concerning. Would they have had that without the shot? I don't know that. I don't have enough information to know that. It's something that should have been reported to VAERS, and if it wasn't, I can't speak to that because it should have been. Everything that happens after vaccine should be reported, and I can't be accountable for what other doctors do and don't do, but it should have been reported. And I think whenever we are giving people vaccinations beforehand, they need to be given all the potential risks. This is something I've always done with my patients, but I, once again, can't speak to what other providers do with their patients. I don't know if that helps answer your question or not.
Senator Abeler.
Well, thank you. And it's, so in my practice, I'm in a different line of work, but when people tell me that this kid that's jumping around the room and climbing over everything is kind of lethargic, I believe them. Like, that's not lethargic to me, but they know their child. Just on the way coming in, I talked to a friend of mine who 24 years ago took his child in for some injections. And within a very short amount of time, he spiked a fever. And they didn't know, and some other things, and he didn't know that was from the vaccine. The doctor says, no, not to worry. They had a series of injections over the next 2 years. The child got encephalopathy, encephalitis, and some regressive form of autism or something like that. And he was 9 months too late to even go to the vaccine court. Everybody says, you got a case here. And so when the doctors, maybe I should ask the Department of Health, when the doctors don't report as a routine to VAERS, how are you supposed to know? How is this committee supposed to know? How is Dr. Klein's committee supposed to know, which actually is better than this version? So maybe I'll just ask I don't want to go on about this, but we do this every year, and it seems like the Republicans are worried about families and side effects and people coming to harm from something that was supposed to be behaving, and the other side is like, no, we just trust the science. And believe Dr. Osterholm, who was wrong on some of this. The COVID vaccine is not as safe as aspirin, which he even impugned me for me saying that, which is fine, I don't care. So maybe to the testifier from the Department of Health, what do you think about VAERS? And do you think people should use it?
Please reintroduce yourself and provide an answer if you have one.
Again, Elizabeth Perilla from the Minnesota Department of Health, Chair and Senator Abeler. We think that VAERS is very important. We do site visits for all of the clinics that are enrolled in the Minnesota Vaccines for Children program at least once every other year. And two of the things that we make sure that clinics are doing, one is they have to be giving the vaccine information statements. If they're not doing that, then we enforce that they need to be doing it. The other thing is that we train them on VAERS. So we really try to get out there and get the message out about VAERS. It is an important system, and it's complementary with the other vaccine safety systems that exist. But certainly, I think it continues to be an important message, and we continue to try to get it out there when we're talking to clinics.
Well, thank you.
Senator
And I'm just
Abeler.
about done, Madam Chair. But I'm just telling you it's not working. Nobody trusts VAERS because as a group, if 1 or 2% report that, statistically, nobody. And so I think the Board of Medical Practice should be cracking down on people reporting to VAERS. I think people should be encouraged to report to VAERS. I think that the people that advocate for this should have wise-eyed open and say, maybe this one isn't quite so good, maybe we should slow it down, maybe we should start at 6 months, not at 2, and all those kind of things that would just make it truly scientific. And so finally, I have more questions about this bill. I don't think it's going, there's not even a House companion to it, but, and I appreciate the integrity of the chair working on this. I know this is important to you, and this is brought with extremely good faith, and I'm impugning none of that. I respect you as a colleague. But I think that letting one person decide this compared to Senator Klein's much broader idea, if you're going to do it, do the scientific whatever thing and make them look at VAERS and be honest about the side effects and be happy that some people choose not to do it and then stop badgering them. People tell me over and over they're badgered about something, and that's not. Medicine and science is like you encourage people with facts. You say, come along, here's a treatment, what do you think of that? And they go like, yeah, I think I'd like that. No, I think I'm going to wait. So that's all, and I just, you can just tell my frustration. I want truth. I want science. I want safe patients. I want no side effects. I don't want anybody who thought the best of what their doctor told them to go home and be disappointed and find out their child suddenly goes from being bright-eyed and active to being quiescent and nonverbal, which happens. And the industry is like, this group of people like, well, those are, how can I be sure it's from that? So anyway, I thank you and good luck with your bill. Thanks.
Senator Coran.
Thank you, Madam Chair. And Senator Abeler's told his story
we're having the same conversation, and the statements are, I think when we heard today introducing the bill is we want clear, stable, and evidence-based information. We want the best available medical science. We want evidence-based standards. And I think every one of those we were told to sit down, shut up, and accept it during the COVID years by all the exact same medical institutions that we should just take it. And for us to modify the immunization, now we're going to take it over, and so Minnesota's version of what our best and trusted medical science is going to be very difficult for people to build trust. We talked earlier in the committee this morning, there's segments of the population, for whatever the beliefs and region of the country that they're not taking them. And we have a lower and reduced population taking them overall. To build that trust back is going to take more than this. This bill doesn't solve that. And what we all fear is the political science is what always prevails. And the political science is what prevailed in 2020 and the harm coming from it. And so Minnesota's going to somehow do it better with the resources. Those resources that we were supposed to trust in a prior administration are the ones who forced it on us and not enforced it on everybody. And now we're saying because you got a new administration and you don't like the policies and we're going to somehow have better science, we actually all want that. We really do. And I don't know how we get there, but there isn't a House companion to this bill. It's likely not going anywhere. And we probably should be working on something that would actually be critical to the health of Minnesota is Hennepin County Medical Center. We could spend 4 hours on that in North Memorial and talk about something that's material and an opportunity, material that we have to address right now. This isn't going to do it. And so I request a roll call, Madam Chair, and I urge that we vote no on this bill.
Roll call requested, roll call granted. Senator Wiklund?
Yeah, I'll just say I think that this bill is meant to help us help the commissioner be able to examine the evidence and examine evidence from multiple organizations so that we are able to provide, clear and stable recommendations. And it doesn't change the process that the commissioner is using as they make decisions, but it does remove a constraint that that's going to, I think, get in the way of their ability to evaluate the evidence from these different organizations. And I'll just say that at the federal level, there was a court ruling yesterday that kind of throws into doubt all the work that had been done over the past few months and ruled that it's not been done in the right way. So I think it creates more confusion, and I think this bill would help ensure that even if there is a difference at the federal level, if there is that sort of difference of opinion or there's a court ruling such as what happened yesterday that puts some of the current recommendations that have come forward into doubt, that this would allow the commissioner to examine evidence from the other organizations and not create a situation where they're unable to move forward. So I think there is a reason for bringing this forward, and I would hope you can support the bill.
Senator Udke.
Thank you, Madam Chair. And a lot's been said, so I won't add a whole lot more, but it was mentioned earlier by a testifier that we want high-quality health care, and I think, there's no argument there. We all want the best health care we can get, and we are home to wonderful health care. A couple of the providers were mentioned, and we've got a lot of other great providers around our state that do a good job. But for me, this is a dangerous policy. We're giving the commissioner all this authority, and to bypass rulemaking, bypass any public process like that, just to move something forward. And basically, we've heard it mentioned already, but to bypass what the federal government is suggesting too. I just think it's totally dangerous. It's the wrong way to go. There's a process in place for a reason, and with that, I would ask for a no vote also.
Madam Chair.
Senator Wiklund.
Madam Chair, Senator Edke, this doesn't indicate any bypassing of rulemaking, and it doesn't say that they can't take into consideration what's being provided as information by the ACIP. It's just saying that they can consider that and the other ones, the other organizations that are listed, and they don't have to all be in alignment. And maybe the testifier, if I'm not saying that correctly, you can correct.
Yes,
Perrella.
I think, sorry, Madam Chair, members of the committee. The goal of this is to keep the status quo. Right now, we're getting questions from schools and childcares because ACIP is differing from other bodies, and with some of the decisions they made, it created confusion about whether vaccines that have been determined to be required by either the legislature or the rulemaking process already, whether or not those are still required. So these changes just help offer clarification so we don't have to continue to refer people to talk to their school's individual lawyer or their child care's lawyers. The two things we're trying to change, the first one is that we're fully blocked from rulemaking. We can't start that process for a vaccine if all three bodies aren't in agreement. So we want to shift that. We don't believe that was the intent, that we'd still have to go through the extended rulemaking process, get public comment, all of that. We think that that's reasonable. This would just allow us to be able to start that even if all three groups aren't in agreement. For the medically acceptable standard, right now that's in rule. It was put in as sort of a simple way of trying to say, we need to be able to tell people how many doses and what timing would be acceptable for schools, so schools can interpret it, so childcares can interpret it. We used ACIP as shorthand. In retrospect, that is causing confusion. So we want to move to a better definition, a more robust definition in statute so that that's more clear. So really, our entire goal is not to change the process at all. We do not want additional powers for the commissioner. We are just trying to make it so we still would be able to do rulemaking, which we have not done since 2013, but if a situation arose, we'd have the option. And so the medically acceptable standard is clear enough that schools, childcares, and medical professionals can understand what we're asking for.
Senator Edke.
That's all. Thank you, Madam Chair.
Senator Abeler.
Well, thanks, and I appreciate the discussion. And, it'd be nice if those two bills could have been presented together. And so there is a need to have public input and process. And Senator Wiklund, your bill probably predates Senator Edke's. You probably didn't work on that together, but you have considerable influence here. And it seems if you were going to get behind something, a broader group like what Senator Edke had would actually bring in public, and then there could be more of this discussion about the VAERS and so on, and just to encourage you about that. So, and just one thing else, I forgot part of my story, and then I'll be done altogether on this topic for the day, I hope. That man who is my friend is driving his son around, who's now 24, nonverbal. They have care all day long. He can barely work. They're driving around tonight eating French fries, listening to Christmas music, which he does every night this time of day. And so the consequences of getting it wrong and over-encouraging on the part of doctors and anybody, there's consequences. And that's all. That's what drives me on my vigorous discussion about this. Just please let people know what is real and let them choose. And most will choose. Thank you.
Any other discussion, members? Any closing comments, Senator Wiklund? All right, with that, Senator Wiklund moves that Senate File 4416 as amended be recommended to pass and sent to the Committee on Education Policy. Ms. Ryan, please take the roll.
Chair Wiklund,
Yes.
Vice Chair Mann,
Yes.
Lead Utke,
No.
Senator Abeler, Senator Boldon,
Aye.
Senator Fate, Senator Coran,
No.
Senator Kupek? Yes. Senator Liskey?
No.
Senator Port?
Yes.
There being 5 ayes and 4 nays, the bill is passed as amended and sent to Education Policy.
Now, Senator Boldon, we'll move to Senate File 3734. And Senator Boldon, is there an amendment?
Yes, Madam Chair, I have the A1 amendment.
And Senator Boldon moves, this is an author's amendment? We believe it is in your packet. Do members find it? Are members finding it? It should be on the top of for this bill, the A1. Does everybody have it? Okay. Senator Boldon moves the A1 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The A1 is adopted. Senator Boldon.
Thank you, Madam Chair and committee members. I'll just note that the author's amendment that we just adopted, part of that was incorporating technical assistance from DHS. The other part comes from another bill that is proposing a change to the same specific mental health service that this bill is modifying. The rationale behind the bill before you today is straightforward. We are all aware that increasing access to mental health services is a need in every part of our state. A key piece to increasing that access is attracting and keeping mental health care staff. To recruit and retain mental health care staff, we must address areas in statute where there is confusing or outdated policies and requirements that are creating frustrating barriers. While specific areas of statutory confusion or constraints can seem small in nature, when added together in our overall mental health system, they are contributing to staff burnout, adding a layer of confusion for those trying to access and provide care, and shutting the door on new individuals interested in entering into the mental health care workforce, something that our state desperately needs. The bill before you today represents many months of mental health stakeholders collectively working together to identify specific areas in statute where we can update mental health service regulations to better fit today's needs. And I want to thank everybody involved for that really important work. This bill language was shared with the Minnesota Department of Human Services, and piece of their technical assistance have been incorporated into the bill and via the amendment we adopted. Bill proponents stand ready to work with DHS on further technical assistance. The intent for this bill is to be policy only with no cost. If any of the provisions are flagged to have a cost, that will be addressed. And I also just want to thank the bipartisan group of senators who have joined me as co-authors on this bill, including Senators Utke, Mann, and Abeler. I'm proud that we are working in a bipartisan manner on these seemingly small but meaningful steps our state can take to help increase access to needed mental health services across our entire state. And with that, Madam Chair, I will turn to my testifier.
Thank you, and welcome to the committee. If you can state your name for the record and begin.
Sure. Madam Chair and members of the committee, my name is Chris Westergaard, and I work at Touchstone Mental Health. Thank you for the opportunity to testify in strong support of this legislation. This bill contains changes to address some of the policies and requirements that cause confusion or frustration for our staff, and for which we see alternative, modernized requirements that could put in place instead. At my organization, our staff are our most valuable part of the services we provide. Due to our statewide shortage of mental health staff, we must do everything we can to best support the individuals who want to enter into this field and stay in this field. I will briefly walk through this bill, and then I'm happy to take any questions along with a few other people here that might help field some questions as well. Section 1 of the bill excludes weekends and holidays from the 10-day window within which a diagnostic assessment has to be completed for individuals admitting to intensive residential treatment services, otherwise known as IRTs. These diagnostic assessments must be completed or signed off by a mental health professional, and many programs just have one individual who can perform this task. And this requirement means that staff are having to work on weekends and holidays and evenings to meet this demand, leading to stress and burnout. This change will ensure the diagnostic assessment is completed in a timely manner while relieving a bit of the stress on our frontline mental health staff. This change would also align with the 10-day window requirement for substance use disorder services that was passed in the last legislative session. Section 2 of the bill aims to clarify an area of the statute that has caused confusion in recent years. Under Minnesota law, the Behavioral Health Fund is used to cover a portion of the cost for intensive residential treatment services and residential crisis stabilization services for Minnesotans on medical assistance and Minnesota Care. In recent years, there have been changes made to this area of the statute dealing with the Behavioral Health Fund, including a change passed last session limiting the use of this fund in certain situations. These changes have resulted in a somewhat confusing statutory language regarding the fund's coverage of mental health service costs. This section of the bill is simply updating statute to more clearly reflect current state law to avoid continued confusion for our mental health staff. Lastly, Section 3 of the bill makes changes to our state's Youth Assertive Community Treatment Program, often referred to as Youth Act. The first change in this section adds a narrowly defined new path for bringing additional qualified mental health staff into this service type. Under current law, the prescriber role on a Youth Act team can only be filled by an advanced practice registered nurse with a certification in psychiatric and mental health care, or a board-certified child and adolescent psychiatrist. Unfortunately, there are very few board-certified child and adolescent psychiatrists in the state, and it's exceedingly hard to find a child psychiatrist for any position. There are more board-certified psychiatrists, and these individuals have as part of their training time spent in child psychiatry. Right now, when a board-certified psychiatrist is interested in working on a Youth Act team, current state statute prohibits them from being hired in the prescriber role. This language in the bill would allow them to serve in the role if they have demonstrated clinical experience and qualifications. The second change would allow registered nurses to be an optional member of Youth Act teams. In some situations, nurses can be a critical part of a Youth Act team. And under current statutory rate setting structures, nurses can't be included or figured into the rate setting structure because they're not listed as an optional staff in statute. If a Youth Act team wants to hire a nurse based on client needs, the position goes unfunded, which isn't sustainable for these programs. Youth Act teams would like to have the option of hiring a nurse to be a part of their treatment team when necessary. The third change would allow a treatment team to provide care to the full range of Youth Act eligible individuals ages 8 to 20 when teams demonstrate expertise in meeting the developmental and clinical needs of that age range. In closing, I ask for your support of this bill, and I'm happy to stand for any questions.
Thank you. We have another person available if there are questions, but just the one testifier. So members, do you have any questions? No questions. Oh. Anyone else? Anyone online have any questions? Well, Senator Boldon, any final comments?
I'm so glad that we've explained so well.
Yeah.
I would just reiterate that it seems like maybe some small tweaks or changes, but these really are places that make a difference for the practitioners who are doing this work, and that is really what we should be doing in order to be sure that we are retaining skilled and expert staff and attracting more folks into this really needed profession, as we do have mental health needs across the state. So thank you for your consideration of this bill.
Thank you. Yeah, I think it's in a non-budget year, if we can make these policy changes that help encourage more people to stay in the field and keep working on the continuum of mental health services, I think that's a good thing. So thank you, Senator Boldon, for bringing this forward. Senate File 3734 will be laid over for possible consideration. Senator Boldon, then you have Senate File 4520. And this bill we are hearing as an informational only because it was just introduced today, and so we can't hear it today and the same day. So we should listen, yes, please. So Senator Boldon.
Thank you, Madam Chair. And I don't know how you want to approach this, but I do have an A1 amendment.
So I think you can, offer the A1 or just for our discussion tonight, and then we'll have to go back and if we're going to incorporate this, or have it move forward, then we'll take it up again and adopt it.
Thank you, Madam Chair. And I'll speak to the A1 and then I'll just speak to the bill as a whole. The A1 just deletes section 1 of the bill. So we just are removing that portion. So this bill overall contains technical and housekeeping updates to statutes related to child care and child welfare. The provisions in this bill have no fiscal impacts. It is policy only. This legislation contains child welfare-related technical fixes and policy clarifications intended to assure consistency with legislative intent without changing existing policy and practice. They reduce confusion and in turn support greater government efficiency in providing effective service and support to children, families, and community and local agency partners. So the first section, so that's section 1 and 2, and then 4 to 7. And then section 3 is a technical change that updates a section of statute to remove language that was inadvertently not removed from statute in 2023, when background studies for legal, non-licensed providers were aligned with federal law. Prior to the 2023 change, these legal, non-licensed providers were required to have a background study every 2 years. Currently, all child care providers, including these legal non-licensed providers, are required to have them at initial registration and again in 5 years before they expire, which is consistent with current statute. These are typically family, friends, or neighbors, but they have met certain requirements to receive payments from the Child Care Assistance Program. I'm happy to go into more detail if members have questions, and also do have folks, experts here able to take questions as well, but that is the high-level overview of the bill, Madam Chair.
Members, any questions? Any questions? No? I see no questions right now, so we will bring this bill back up for a actual hearing if we are going to make it move forward, if the language is going to move forward. So thank you, Senator Boldon, for presenting. And next you have another bill, Senate File 4523, and that is also informational, and there are no amendments. Senator Boldon.
Thank you, Madam Chair. This is a bill to establish a standardized licensing framework for the Board of Pharmacy's various license or registration types, to align regulations with modernized practices, and to ensure expectations are clearly defined for applicants amidst licensing fees, which fund not only the board's daily operation, but also the state's opioid epidemic fund. The Board of Pharmacy licenses or registers more than 26,000 individuals and entities, each subject to distinct statutory requirements. These licensees or registrants include pharmacists, pharmacies, technicians, interns, manufacturers, wholesalers, third-party logistics providers, and medical gas dispensers. The board has undertaken a broad modernization effort, transitioning from paper-based renewals and workflows to online systems. And as those systems have evolved, it has become increasingly clear that standardizing the licensing framework across all of these license types provides significant benefits, improving clarity and consistency for licensees while enhancing efficiency. So some of the key points I would mention is that it creates a standard 12-month validity for all applications. It clarifies expectations and procedures for relocations, ownership changes, and business changes. It clarifies posting requirements. It now opens online renewals earlier, 3 months before expiration, which improves workflow and reduces last-minute submissions. There's some statutory language that will define how long an individual or entity may late renew before reinstatement is required. And then there's some language for pharmacies around inspection-related licensing authority. The board may refuse to issue or renew a license or deny a category of licensure if inspection deficiencies have not been corrected. So the proposed statutory updates create a more consistent and transparent licensing framework and reduce administrative complexity, strengthening the Board of Pharmacy's ability to carry out its mission effectively. These changes support timely renewals and provide clearer expectations for applicants, contributing to a more modern and efficient regulatory system. And with that, I will turn to my testifier, Madam Chair.
Thank you. Welcome to the committee. If you can please state your name for the record and begin.
Sure. Thank you, Madam Chair and members of the committee. My name is Dr. Katrina Howard. I'm the Deputy Director at the Minnesota Board of Pharmacy, and I'm here to testify in support of Senate File 4523. That was a very excellent overview, and so I'm happy to take any questions. I know that there's a lot in this bill, but overall, again, we're just trying to standardize the way that the various license types are processed. It's appropriate that they do have their own regulations, but to be able to have a blanket, all applications are only valid for 12 months, and then thereafter, if it's incomplete, for the board to be able to cause it to expire. There's some additional points I would just like to make, like the bill does not increase fees or create new fees. It simply clarifies how existing fees are administered and ensures that applicants understand expectations and timelines. Again, all current fee structures remain unchanged. As far as the bill providing clarity for expectations regarding relocations, ownership changes, and business structure changes, it is of paramount importance that the board knows who its licensees are as well as the owners thereof, as the businesses that the board licenses play a direct role in the drug supply chain. So it's preventing bad actors in the drug supply chain is a charge that the board takes very seriously. Furthermore, if the board receives an application within 90 days of that license type's expiration, the board can extend that expiration date to the following year in this bill, as opposed to granting a manufacturer license and then saying this is valid for 1 month, now turn around and submit a renewal. So just trying to bring standardization, clarity, transparency to the way that the board conducts its operations for all of its license types. And with that, I'm happy to take any questions. And also, Dr. Erin Patterson, the board's executive director, is with me if there are additional questions.
Members, any questions about the bill? Senator Abeler.
Well, just an easy one. I just like reading repealers. And I presume that subdivision 1 is all rolled back into there somewhere in the repealers. And number 2, you had a working group or whatever. So did you need a law to have a working group, or you just decided to put it in statute at one point for the heck of it?
So,
Ms. Howard, or Dr. Howard?
thank you, my apologies. Actually, that was the working group for the continuing education task force was actually identified when we submitted this language to the revisor's office. They questioned if it was obsolete, and it has been not in use for many a year, and so I can't even speak to the history of it. And so because
That's fine. I just,
Senator Abeler?
no, that's all. It's petty.
Any other questions? Senator Utke?
Thank you, Madam Chair. You hear about, I mean, everything's going to be more streamlined and better, but in the bill, would it require, when it comes into the new licenses, and there seems to be a little hesitation on the new licenses, if they were just registered by the board, and then a month or two later, the facility changed owners and such, and they'd be relicensed again. Licenses aren't they're by the individual, not by the business. And so is that the way it works? I mean, if somebody just renewed, the next person comes in, has to pay again. It's not by the business.
Dr. Howard?
Thank you for that. That's a very important point. Licenses and registrations are not transferable by the board. And so you may realize that the board has fairly steep licensing fees. And so for an opiate manufacturer, it's $55,500 annually for that renewal. And then for non-opiate manufacturers or wholesalers, it's $5,500. Well, the board and the statute only permits the board to charge that full fee once per fiscal year. And so if the board were to then receive a change of ownership application thereafter, it would only charge the $500 administrative fee for processing that.
Senator Utke?
Thank you, Madam Chair. That
Okay.
clears up what I was looking at.
Okay. Any other questions? No? Seeing no other questions, Senator Boldon, anything else? This is another one that we will bring before the committee in a formal way to take action on it at a later date. Thank you. And now we have Senator Abeler.
How you doing? I'll let you go through most of it. Sure.
Members, this is one that is not introduced yet, and this is an informational hearing, and you have the revisor file in your packet, and
Well, thank you, Madam
Is it-
Chair. There's a pretty good
Senator
crowd, and I
Abeler.
think the online audience is pretty massive, anticipating this piece of legislation. If you enjoyed the last one about the pharmacy board, I appreciate that, but this is the one, Madam Chair. This is the one you've been waiting for, talking about variances and just fascinating stuff. I just would comment, Madam Chair, when this becomes a bill, it would be liable for an addition of something that happened last year to kind of fix it, to make sure people are served in better ways in their health care. But that's a different topic for a different day. So, Madam Chair, I've got a testifier, and she can introduce herself, and we'll be very succinct in her testimony. So,
Thank you.
welcome to the committee, and if you can state your name for the record and begin.
Thank you. Chair Wiklund and members of the committee, my name is Dr. Ridge Pitty, and I am the Executive Director for the Minnesota Board of Chiropractic Examiners. The mission of the Minnesota Board of Chiropractic Examiners is to protect the public through effective licensure and enforcement of the statutes and rules governing the practice of chiropractic, to ensure a standard of competent and ethical practice in the profession. The board provides core public safety services through regulatory oversight to ensure both high standards of chiropractic practice and excellent customer service to the general public, consumers of chiropractic services, applicants and licensees, and students and faculty in chiropractic academic programs. The board was established by legislative act in 1919 and currently has 3,224 licensed chiropractors. Licensed chiropractors also have the opportunity to maintain registrations in 5 different areas, including acupuncture, animal chiropractic, graduate preceptorship, independent examiner, and professional firms. Today, I'm here to testify about changes to our statutory language. Changes include the following. Definitions. We've moved good standing and voluntarily retired from rule to statute. We added reinstatement and clarified therapeutic services and acupuncture. Finally, we alphabetized all definitions. We're updating the reinstatement requirements for voluntarily retired and board-terminated licenses. Currently, once a chiropractor is licensed in Minnesota, they are always licensed in Minnesota. All accrued fees and interim continuing education for time not actively licensed in Minnesota must be completed upon reinstatement. This poses a large hardship for individuals who left practice for a variety of reasons. The board has 3 statuses that we are hoping to simplify: voluntarily retired, board terminated, and inactive. By capping reinstatement fees and continuing education requirements, there is an opportunity to reduce the burden for previously licensed individuals who are seeking to return to practice. The language proposes consolidating and simplifying the reinstatement requirements. For voluntarily retired licenses, it includes payment of the renewal fee and continuing education, as well as any outstanding obligations that were at the time the license was retired. For board-terminated licenses, it includes payment of an application fee, the renewal fee, continuing education, and any outstanding obligations at the time the license was terminated. The inactive status would be eliminated with the changes in the reinstatement requirements. It would eliminate the need for that inactive status, and those currently inactive would be moved to voluntarily retired. Again, this is an effort to consolidate and simplify the license status. We also have inactive registrations for acupuncture and animal chiropractic, and again, with the change in reinstatement, that would eliminate the need for those inactive statuses. For independent examiners, which are doctors of chiropractic who complete patient examinations for insurance, workers' comp, and other similar and related claims, we're proposing to allow the examinee of those exams to have a third party be present during the independent examination. We are proposing an administrative hold during complaint resolution. So a license will not be board terminated or voluntarily retired if there are open or pending complaints. For insurers, the current language is vague, reading 2 times each year. So we would like it amended to January 1st and July 1st. And finally, changes to the penalty for continuing education audit failure. The board currently has authority to assess a fee of up to $900, and rather than making it a subjective fee, it will now be tied to the renewal fee. The first CE audit failure is 1 time the renewal, the second failure is 2 times the renewal, and the third and subsequent failures are 3 times the renewal. Thank you to the committee members for the time to hear the proposals from the Chiropractic Board. I'm available for any questions.
Thank you. Members, are there questions, any questions or concerns? Anybody online have any questions? No?
Madam Chair.
Senator Abeler.
Well, thank you. I hope that people were paying attention during this, I don't know, I would call it riveting discussion. I think the idea about alphabetizing definitions, I think, could take place in many parts of government. And once again, the Chiropractic Board is leading the way. And finally, I'd like to draw attention to page 17, section 18, where the revisers are given not 1 but 2 columns to work on with their revising. And so I think the revisers are going to have just a great time this summer, Madam Chair, should this be able to go into law. So thank you very much.
Thank you for bringing that to our attention. And this is another one we are hearing informationally, and if, when the bill is introduced, then we will bring it back before the committee for a hearing, so. Next, I have a couple bills, but we will skip over the 2 next bills and go to informational hearing of the DHS OIG bill, which is numbered 26068084. And I'm not sure if there is an amendment that would be offered. Do you have it, or is it in our packets? It was passed out, okay. Oh, here it is. Members, this is the DHS OIG policy bill, and we are hearing it informationally. And we have Ari Didion here from the department to give an overview of the bill. And so, Ms. Didion, you can proceed.
Thank you, Madam Chair. For the record, I'm Ari Didion. I'm the Legislative Director for the Office of Inspector General at the Department of Human Services. And I might be giving Senator Abeler a run for his money with weedy, dense regulatory bills here. This is the OIG policy bill. So this contains a variety of no-cost provisions, some of them very technical, some of them a little bit more substantive. So I will walk through that quickly for you all. So this bill contains a couple of proposals related to background studies. One of those is, and it's sections 13 and 18 through 21. This is a set of changes related to background studies.
I'm sorry. I'm just going to interrupt. I wanted to let members know that there is a bill index, and it has 2026 OIG policy bill index on the document. You might want that to be handy when she's going through this. I'm sorry, please proceed.
Thanks, Madam Chair. So the background studies disqualification changes, like I said, those are sections 13 and 18 through 21. Our background studies staff regularly reviews the disqualifications in Chapter 245C for federal compliance and to conform with changes to criminal code. And so these are a set of changes related to that. One of those is adding a order of protection for financial abuse of a vulnerable adult as a disqualification. This also adds the new anti-kickback or illegal remuneration crime that was created last year. It corrects a change that was made in the 2024 session, which removed the interference with privacy at the gross misdemeanor level. I think we believe this was done unintentionally. There was other changes being made to the chapter that were similar. So that's added back in. And then this also corrects a change. There are a couple of background studies that have kind of a different disqualification period. Most of ours are 7 years, 10 years, 15, or permanent. A few years back, there was a 5-year disqualification created for crimes related to like substance use disorder and drug-related crimes. And then also last year, we created a new 2-year disqualification that responds to fraud, waste, and abuse. And so this just corrects the statute to say that those shorter disqualifications do not apply to family child foster care background studies, which has a federal requirement that it have that longer disqualification period. The next background studies change in the package is an update related to our Net Study 2 system. We put this into effect originally. I think we started implementing Net Study 2 over a decade ago. Most provider types have been switched into Net Study 2, which is the system we currently use to process background studies. Child and adult foster care and adult day services, there's a county component there, and those are still in the old system. And so this language just effectuates getting those last few study types into Net Study 2, that is sections 15 and 22. The next proposal is a couple of cleanup and technical items related to background studies. Section 14 just removes an outdated term, or just adds a current term. This is already how studies for child foster residence settings are processed in Net Study 2. So this is just conforming statute with the current practice for those studies. And then Section 23 relates to a proposal that DHS proposed, I believe, in 2024 and was passed by the legislature related to a limited scope of set-aside for, I believe it's foster residence settings and children's residential facilities. And this change in the policy bill just removes language that we uncovered as being problematic to implementing that variance. And then the last background studies change in the policy bill is background studies federal compliance. And so this relates to its sections 16 and 17. Section 16 just clarifies that child foster care studies are not transferable across all programs because they do not have similar requirements. And then Section 17 is related to childcare, and this aligns with childcare development block grant requirements in order for us to keep getting data, FBI data for childcare background studies. And then jumping into licensing, we have a proposal that closes a, what we call a loophole in our change of ownership. Currently, a change of ownership for a license is not required if at least one individual is, at least one controlling individual has been affiliated with the program for the previous 12 months. And we've found this to really diminish the insight we have into when these changes of ownership are taking place and who is controlling the programs we've licensed. So this removes that loophole, and that one is sections 6 through 11, and then there is also a repealer related to that change. There is also a proposal from our substance use disorder treatment and mental health area in licensing. This one's pretty simple. It just removes a requirement for a standing order in order for programs to maintain a supply of nasal spray opiate antagonists such as Narcan. So this just makes it for substance use disorder treatment, children's residential facilities, detox programs, withdrawal management, and IRTs. This just makes that a little bit easier to maintain that supply. The next proposal is a bunch of very technical fixes related to licensing. One of those is repealing DHS as the lead investigative agency for psychiatric residential treatment facilities. This is current practice, and currently it's being executed through an interagency agreement between DHS and MDH. And so sections 30 through 33 codify this practice. And then sections 24 and 25 relate to clarifying some technical items in HCBS. These are to align what's in Chapter 245D with the positive supports rule, and then just making sure that's very clear in licensing statute that residents' rights to safe and non-hazardous residence is not a licensing requirement that can be waived. There's also in Section 10 a licensing renewal fee cleanup. A couple of the higher fee amounts did not have that or equal to language, and so it unintentionally excludes revenues that are exact amounts. So this aligns with the other fees that were updated last year. Section 11 adds a licensure fee for the EIDBI provisional license. This I just think didn't get caught last year with the new provisional license and all of the changes to other licensing fees. Sections 8 and 9 relate to temporary immediate suspensions for licenses. Some of you all may remember we were before this committee with changes to our temporary immediate suspension. In recent years, language that we added last year that was intended to respond to fraud ran into some conflicts with other language already in the temporary immediate suspension section. And so this makes clear what the standard of evidence that DHS needs to meet is, and also corrects an issue that allows us to move into a suspension following a temporary immediate suspension related to the outcome of an ongoing investigation or judicial proceeding. This new temporary immediate suspension provision didn't contain the same language that other TIS provisions contained. So this is just coming into line with that. And then sections 4 and 5 relate to clarifying the definition of related individuals in 245A to align with the definition used in the Community-Based Services Manual for disability waiver services. And so this is intended to address situations where the license holder is providing services to a spouse's relative or another family member related by marriage. And that was, I don't know if I said, that was sections 4 and 5. And so that was the licensing technical package. And then the last set of proposals I have to talk to you about today are from our Program Integrity Oversight Division. We have a proposal related to surety bonds, which is the purchase of surety bonds are required for PCA/CFSS providers. But we've run into issues trying to correct and I will note, this language is not currently in that reviser's file. We caught that on review, so we're just hearing this informationally today, but when the bill is heard, we plan to have an amendment that includes the language related to surety bonds. We've run into issues with the way bond companies are interpreting the requirement. It's an annual requirement, and we've been running into issues saying that when we have claims spanning multiple bond periods, they're only paying out under one of the bonds. And so this clarifies statute so that it's clear that each bond is its own obligation. And so this would help us recover funds when there are multiple surety bonds in place. And then we have a set of returning or cleanup. I would say these are not all clarifying. Some of them are returning from last year. Others are clarifying changes from last year related to program integrity. Section 3 is this provision was in the governor's fraud package last year. It was in both versions of the omnibus bill. But during conference and special session negotiations, this was ultimately removed. This allows us to, we currently have the ability in 245095 to stop payment due to a credible allegation of fraud and a pending investigation. This expands our authority to be able to stop payment if we've revoked or suspended a license, if there's a criminal conviction of fraud in another state or federal agency, as well as withhold payment following a background study's disqualification of a controlling individual. And that is Section 3 of the bill. Section 1 of the bill is an exception for DHS to Chapter 15.013. This was new language that was passed last year related to agencies' ability to stop payment. The language in Chapter 15 includes a right to appeal via a contested case hearing and a 60-day limit, which is problematic for DHS investigations because when we stop payment, it is often due to a criminal referral, and criminal investigations often take longer than 60 days, so we need, that time limit is problematic. Additionally, having a full contested case appeal could jeopardize criminal investigation from both the agency and the provider perspective, because an appeal could make documents relevant to the criminal investigation. Documents for that could be brought up in the appeal. So we have concerns about that. I know that there are kind of several bills out there taking different approaches to this. We chose to put the exception in our statute. And then Section 2 is a very clarifying change. It's a change to 245095 to align with the new background study disqualification to address fraud, waste, and abuse that was created last year. Section 27 is another clarifying change related to pre- and post-payment review. The agency already has authority to conduct prepayment review, but we felt like this could be stronger, and so we tightened up that authority and ensured that we could take action based on the review. And then the next proposal out of the program integrity area is expanding DHS's authority to conduct site visits. For medical assistance, currently, we only have the ability to conduct a site visit when the provider has submitted claims. And this would give us the ability to go on site prior to them submitting claims as soon as they're enrolled. Providers can be operating once they enrolled, and they have up to a year to submit claims. So we think this is an important measure to allow us to get on site earlier. And I'll note that this authority was added for EIDBI last year, and so this is just extending this to all provider types in the Medicaid program. And then we have another pretty simple one, but really important, adding the definition of fraud to 256B. Currently, Chapter 256B, where we have all of our Medicaid requirements and our related program integrity provisions, there is no definition of fraud. It currently exists in rule, and so we're moving that from rule into 256B to help increase our ability to send referrals to the AG's office as new crimes come online that fit this definition. And then the last proposal from the program integrity oversight area relates to waiving notice to consumers when they're under investigation. Currently, DHS is required to provide a 180-day notice prior to utilizing the authority to subpoena bank records. This is a really time-consuming process. It can slow down investigations. And so this would allow us to waive the 180-day notice if it would help protect the integrity of an ongoing investigation. That is the OIG policy bill. Happy to take any questions. Thank you.
Thank you. Members, do you have questions? Senator Abeler.
Well, thanks, and I've got a number. So I appreciate you coming here. One of those different versions is mine. And I'm happy, looking forward to working with you all on this. I'll just flag some of the things that I notice. And we had an interesting meeting with the commissioner and Mr. Clark, and they couldn't say enough times that they're against fraud, and so are we, and we know that. So I'm just willing to put that all aside, that who can be tougher on fraud, but we're all against it, and I think this session will come up with some good collaborative work. One of the concerns I have, which I've said many times, is the catchment of individuals who really didn't do anything wrong. And I believe some number of your 540 cases are people who are being subject to an inappropriate definition that upon further review will be dismissed by the Attorney General and not even charged. I just have that imagination talking about this. But so there's a number of things. And this, starting with, I'll just list them, you don't have to reply unless you want to, but like even the delaying notification part, there's an idea here in being tough on fraud that people are guilty till proven innocent. And that's a real problem for you as an enforcer, but the people as innocent, erroneous people who may have a staff that did an error that looks like it's something horrible. And that first thing there is just something that could be at risk about that. On page 2, line 14, this credible allegation of fraud that needs to be really beefed up to be something that people know. You'll know it when you see it. It's clearly, and it's like, according to Mr. Clark, you don't really do fraud hotline complaints, well then don't have it. And so all the other things make sense to me, but then when you get, what page was that about the indictment thing? When you get to page 43, line 32, allegations are considered credible. They have an indictment of reliability. That's in line 43.32, which is the lowest of all possible bars. DHS has the privilege of using the word preponderance a few times when they get to do stuff. I think this, if you're going to do this, it needs to have a preponderance. That's just like more likely than not, 51%. It's not like clear and convincing or beyond a reasonable doubt. But I think if you did that, you would have less dolphins in your tuna net, if you will. And so I think if we can get that clear, I think that will help quite a bit. So that's something you need to work on. This online 4.11, this existing law, talks about administrative reconsideration. I've tried to help some people get expedited reviews and reconsiderations, which simply do not happen. In one case, even mailed the person the response that they were not going to give them an expedited reconsideration, which I thought was really ironic. They were just at home having a heart attack. Should we go get a loan to keep paying our staff or not? I'm trying to go kind of quick through here. It's just a number of things, and this is a big deal. And I think at the end, as we all work on this together, we'll come up with a really good product. So, trying to find the next thing here. I appreciate adding some of those crimes to the bars. Those are certainly appropriate, and I think you'd find nobody objecting to that. Should have had a Post-it note. And again, 42.12, this fraud definition, it seems fine, but I just want to make sure that we all agree. And what's not happened in any of this work has been an inclusion of, well, us, except for what we passed into law. But the provider community, the well-behaved ones, the ones who actually take Medicaid clients and make a living at it, that don't drive fancy cars, that are committed to the work, we need to include them and helping them. They're just as interested as anybody else. And, you know, the clients at some point are interested, but, you know, they may have some comments as well. What they're able to see, is there a client complaint that we could stick into here? Maybe that's already there, I don't know, but that's something we want to think about. On line 43.5, it talks about reasonable and medically necessary services. The debate on what's reasonable and necessary is huge. I have 47 years of haggling with insurance companies about what's reasonable and necessary. And actually, Senator Utke and I might be on different sides of that discussion. What? That's way too much. But I think in terms of being something that we're going to ding somebody for, one person's reasonable is another person's excessive, just by maybe a matter of a little bit, but now it's no longer reasonable. And just to point out that to you. And on line 44.19, I don't understand this, and maybe you can explain it to me, the withholding of payments. You're taking away somebody's due process. And that, just on that, using that word, there's a ton of due process issues here on the guilty till proven innocent philosophy, which the department has moved to, which is actually causing harm to some of the clients we want to serve. We talked about all these 540 cases a couple days ago. Who's going to serve the people? And there's literally thousands of people. And so, but could you comment on line 44.19 about that it's not subject to appeal? I know you mentioned that. But they're, anyway, we can take this offline too, but I just think there has to be a way to go like, what did I do? And is this for a really serious case? Is that the intention of 44.19 and 20?
Ms. Didion, if you have a quick
Madam
comment.
Chair, Senator Abeler, I believe that at least part of the reason that we included this was to differentiate our payment withhold authority from the new payment withhold authority issued in created in Chapter 15, but I can get more information on if there was something
Okay.
specifically triggering that change.
Well, I think, yeah, I just think they'd rather not, I'm sorry, Madam Chair. I'm just taking over your meeting. I'm almost done. But I think that actually relates back to 43.32, this indicium of reliability, which I don't know if that's even a legal term, but it's a pretty cool one. But it troubles me, and I just think I'm worried about it. There's only one or two more things. Finally, Madam Chair, on line 49.7, this new background studies thing, can you explain why you're disallowing what was just fine before and they have to get a new one? On page 49, section 34.
Ms. Didion?
Madam Chair, Senator Abeler, that is related to the provision moving those providers that are still in the old background study, the net study without a 2.0 system, and so this is related to that change.
Senator Abeler?
So that's not somebody who had, so that's a small group of people? Okay.
Ms. Didion?
Madam Chair, Senator Abeler, yes, it's, I will double check what my providers, it was child and adult foster care and adult day service providers
Okay, and
that would need
Senator-
new background studies.
so Madam Chair,
Senator
they
Wiklund.
got they got a more limited study. This is a more complete study, and then they're good to go.
Ms. Didion?
Madam Chair, Senator Abeler, this, the old system is now no longer supported, so they wouldn't, studies, they wouldn't be in our current system, Net Study 2.0. I don't know if it's a different standard, but they're currently in a system that we're retiring, and so that's the impetus for that change.
That's helpful. My final
Senator
comment on
Abeler.
this bill, Madam Chair. Just back to the background study stuff, they're still a mess, just to report back to you all. And it's not simple, they're not cheap, they're not available all the time, and the delays in getting one, some people quit and just don't work for that company. They don't even take the job. So just feedback to you, we've talked about this 50 times, if we've talked about it once, literally 50 times. And we've been assured not to worry, just since you're here and going back to the home office, you can say, and so we still wonder why you can't go to a police department, why you can't go to somebody who's doing this stuff anyway, especially in greater Minnesota or someplace. You've been through several vendors, and I'm just telling you, it's on my mind, especially if you're making people do one when they just had one. So thank you. Appreciate it, Madam Chair.
Thank you. Any other questions or comments about this language? Senator Coran?
Thank you, Madam Chair. And Senator Abeler covered a bunch, so I'll only make a couple comments. Is relative to the background studies and the vendors in rural Minnesota, you know, the switch to whatever vendor we have today, I had the privilege of having my fingerprinting done because my wife runs a daycare. And we have to have those services available where it's actually a priority. Right, when you go in, the one that we had closest to us was a Radio Shack in Pine City. Their priority is not doing background study or the fingerprinting work. So you sit there and you wait when it's convenient for them, and it's not convenient in any way, shape, and form. And so that's just one. The other piece I saw related to kickbacks. So I see there is a 15-year disqualifying for kickbacks. Does this bill accommodate the recent, the OLA report that was released today to clarify kickbacks in state statute for the omission that DHS claims to debate or have a debate between the the OLA and a 1995 state statute or reference to the improper definition of kickbacks to put it under the authority so they can be prosecuted accurately?
Ms. Didion?
Madam Chair, Senator Coran, I am still getting familiarized with the issue in the OLA report, so I don't know about a 1995 statute. However, we passed a state anti-kickback package. We proposed this, you all passed this last year, so we do now have a state-level anti-kickback statute, and that's both an administrative offense as well as we added that to criminal code last year. That did not exist in state law, to our understanding, only existed in federal Medicaid law prior to last year.
Madam Chair?
Senator Coran?
And so on the kickback, from what I can see so far, and absolutely any vendor that participates in that fraud through that methodology of providing kickbacks or incentives, which we've seen in a variety of programs, is there anything in new that you've added that actually has a significant consequence for the recipient of those said kickbacks, prosecuting the individuals? we always talk about the provider, but this is in tandem with people who claim to need vital services. Clearly, they don't if they're participating in some kickback scheme. So have you looked at, and does anything in this bill include those that defraud from the supposed recipient side in the kickback scheme?
Ms. Didion?
Madam Chair, Senator Curran, the anti-kickback law primarily targets provider fraud. However, the anti-kickback law made it illegal to provide or accept kickbacks under medical assistance, so it applies on both ends.
Madam Chair?
Senator Curran?
So then, do you expect then we'll finally see your agency and the OIG prosecute the recipients as well of those kickbacks?
Ms. Didion?
Madam Chair, Senator Curran, investigating recipient fraud is more of a county function. I can certainly go back to my folks and get more information about how that applies, but I don't have information with me today that I can speak to on that.
Madam Chair, that's all
Senator
I have.
Curran?
Thank you.
Okay, thank you. Anything else right now? This is informational hearing, so, you know, I hope that Senator Abeler, you're continuing to work. It's an area, it contains a lot of provisions that we have interest in, so I hope you're continuing to work with the department on.
And Madam Chair, I
Senator
just want
Abeler.
to thank the department for their open-mindedness, and we all want the same thing. And so we want to make sure we just totally, hammer on the people that are just the bad actors, and then make sure that the people that are watching at home trying to provide these services actually get to do it. So, thank you.
Thank you. And so we will bring this back forward for a full hearing in the future when it gets to be jacketed. And now I will, I will move to Senate File 4419 and 4091, and if Senator Boldon can chair.
All right, Senator Wiklund, Senate File 4419. I believe you have an author's A2 amendment that is being handed out to members. Do you want to say anything about that amendment?
I will, I'd like to move it as an author's amendment, and then I would like my testifier can talk more about the bill overall and where these items came from.
Very good. Senator Wiklund moves the A2 author's amendment. Does everyone have it? All right, all those in favor of the A2 amendment say aye. Aye. All those opposed say nay. The ayes have it. The amendment is adopted. Senator Wiklund, to your bill as amended.
Madam Chair, this is a bill brought forward by the Department of Health, and it has items collected together that have impact in the commerce realm. And so we are hearing it tonight, but then we will be moving it to be heard in the Commerce Committee, and I will turn it over to my testifier, Lisa Timian.
Ms. Timian, please introduce yourself and proceed.
Yep. Madam Chair, members of the committee, for the record, my name is Lisa Timian, and I'm the Director of Government Relations for the Department of Health. I will say that this just has a number of technical provisions, as Chair Wiklund mentioned, that have to do with our health policy division at MDH, which overlaps with jurisdiction in the Commerce Committee space. So one of the pieces is their federal conformity about the electronic drug authorization standards and transmission requirements. And this is really just something to make sure that we're all talking the same language electronically. Another portion is that we have this existing statutory exception that we have been doing for the last 16 years since federal changes with the Affordable Care Act. We're now just going to make that temporary exemption permanent. It's just about essentially like workers' comp and other products that aren't health insurance, and so they're not subject to health insurance requirements. Also, it removes obsolete statutes, so just things that are been on the books for a while that are no longer relevant or in use. We make modifications to the prescription drug price transparency reporting requirements, as well as streamlining the pharmacy benefit manager data sharing that we do in conjunction with our colleagues at the Commerce Department. We also just update some 62D requirements, which is the Health Maintenance Organization statutes, some technical cleanup of network adequacy statutes, and then perhaps most interesting is just aligning the immunization coverage and ensuring that health insurers who have so far offered to continue offering insurance, no-cost copay coverage for immunizations through 2026. This would just extend that going forward in line with current status quo.
Very good. Thank you. Senator Wiklund, anything else before we move to discussion? All right, members, questions or discussion? Senator Abeler.
Well, thanks. Just in the repealers, I appreciate the bill, and it's, anyway, I think my bill was cooler, I have to say, but anyway. So the, on the repealer, line 1R, the 62D08, that report, is that change reporting of administrative expenses? It looks like you're repealing the report.
Ms. Timian.
I'm just going to ask one of my subject matter experts. I get really quickly over my skis here, so I don't want to misspeak. Yeah, just.
Welcome to the committee. Please introduce yourself and go ahead.
Thank you, Madam Chair and members. For the record, my name is Diane Rydrick, and I'm the Director of the Health Policy Division at the Minnesota Department of Health. And just to clarify, the question is about the repealers in 62J, Senator?
Senator Abeler.
62D, it's on the 1R, it's the second from the top. The annual report about administrative expenses. Are those still, it's being repealed for some reason. It seems like you'd want to know those. You can go take it home to your home office and find out if you want.
Yeah, my apologies, Madam Chair and Senator. Lisa has phoned a friend, and her friend may need to phone a friend on this one.
That's okay.
If you can give us a moment.
Sure.
Mr. Hudella has some information for us.
Thank you, Madam Chair. Senator Abeler, that provision, the repealer is pulling it out of the annual reporting requirement. Elsewhere in the bill, they insert it in language relating to the quarterly reporting requirement. But maybe Ms. Timmon can speak more to it now.
No, if it's just put somewhere else,
Senator
I don't. Sorry, Madam Chair, if it's just put somewhere else, I don't mind. So I just, thank you. That's what you have friends for.
That's what we have good counsel for,
Ms.
too.
Timian.
Thank you.
So it's, I don't want to take away your thunder. Were you going to ask about the insolvency changes, or do you want me to ask about that? Okay. Back in the repealer stuff, it talks about, is this about UCare? Is this, like, it just says, well, on page subdivision 9, if it's, you know, if it's, so none of this has anything to do with the UCare conflagration. Is there any language you're going to bring forward about that?
Ms. Timian.
Madam Chair, members of the committee, We will be having some discussions generally as part of, between the governor's budget proposal that came out today, but nothing in today's proposal really has anything to do with that situation.
Thank you.
Senator Abeler.
That's all I got. Thank you.
Other questions, members? Seeing none. Any final comments, Senator Wiklund? All right. With that, Senator Wiklund moves that Senate File 4419, as amended, be recommended to pass and sent to the Commerce Committee. Ms. Ryan, we did not have a roll call. All those in favor say aye. Aye. All those opposed say nay. The ayes have it, and the bill is on its way.
Could have roll called that. It would have been a heavy roll.
Next, Senator Wiklund, we will hear Senate File 4091.
Thank you, Madam Chair. And Senate File 4091 is also brought to us by the Department of Health. And I have an A1, excuse me, the A1 amendment, and I believe that that is in your packet.
Senator Wiklund moves the A1 author's amendment, which is in members' packets. All those in favor of the A1 amendment say aye.
Aye.
All those opposed say nay. Ayes have it. The amendment is adopted. Senator Wiklund, to your bill as amended.
Thank you, Madam Chair. And this is a bill that is sort of a health policy minibus. And so it has multiple provisions in it, and I will let my testifier go through the overview. Thank you.
Ms. Timian, please reintroduce yourself and proceed.
Madam Chair, members of the committee, for the record, my name is Lisa Timian. I'm the Director of Government Relations for the Department of Health. So this bill combines 6 different proposals that we're advancing, that we're hoping to advance this year, that only belong in the jurisdiction of this committee. So the first part is updating our palliative care advisory council reporting timeline. Currently, it's required to have an annual report. In talking with the committee and staff, thought made more sense to make it a biannual report. It's not an area where there's a lot of change that happens on an annual basis, and it also better reflects that it is a volunteer committee. We are also streamlining our suicide prevention reporting. Right now, we have 2 different reports that come out on alternating years. One focused on 988, which is the state's suicide and prevention lifeline, and then suicide prevention reporting generally. This combines those into a biennial report, so every 2 years, just with a more fulsome update on what is happening with 988 and suicide prevention in Minnesota. We're also making a federal conforming change for the contract term limits for the state's WIC program. Under current state statute, those terms of a contract are only for 5 years, and this would extend to 10 years. This is just a federal conformity issue that aligns with guidance from the U.S. Department of Agriculture, who oversees the WIC program, and it makes that service more streamlined and also improves service continuity for the families who rely on those nutrition benefits. Section 6 is the allowing tribal nations to participate in our State Community Health Services Advisory Committee. This is our key public health advisory committee made out of county commissioners and community health boards from around the state, advising the commissioner on matters related to the department, including community health services in Minnesota. In current statute, only community health board members can be members of SHAC, but by allowing tribal governments to participate in this advisory committee, it will strengthen our partnerships and improve our statewide public health system. It's really just a long overdue recognition of the key role that tribes play in our statewide governmental public health system. Importantly, this is recognition of tribal sovereignty, and that the 11 tribal nations are able to join at any time, but are not required to join. Sections 7 through 9 are audiology and speech language pathology updates for the licensing of those professionals. And then Section 10 is a repealer for a program that no longer exists, so we're just cleaning up statute.
Very good. Thank you. Questions, members?
Sorry,
Senator Utke.
got no questions.
Thank you, Madam Chair. And going back to the last page of the bill under the repealer, we're repealing something that was just added a couple years ago and funded. Can you further explain what's going on there?
Ms. Timian.
Madam Chair, Senator Ecke. So yes, that program was funded in 2023, but it was only given 2-year funding. So that funding expired at the end of 2025. But I think there was a lot going on in 2023, and we didn't realize that we had codified something that was only going to be a short-time program. So in looking at our statutes, we just wanted to make clear that that's no longer a program that we have.
Senator Ecke.
Thank you, Madam Chair. I had another question or two, but it actually got answered during the presentation, so thank you.
Other questions, members? Seeing none. Any closing comments, Senator Wiklund?
No.
All right, we will lay this bill over for possible inclusion in a future omnibus.
Thank you, thank you.
I will pass the gavel back to Senator Wiklund.
Members, we were just discussing, it is 7:30, and we had indicated on the schedule that we would go till 7:30. We have 3 more informational hearings of language. We have the revisor files. They are agency, DHS agency bills. We can go through. We can continue if you'd like, or the alternative would be that we'd have to put them on tomorrow's agenda, which is, I don't know, it's got some discussion time that we wanted to allocate to different program integrity bills. So would you like to just continue and get through this tonight? That would, yeah.
I'm good with
Yeah.
that, Madam Chair.
Madam
Okay.
Chair, we're having so much fun. Let's just
Yeah.
Oh.
go
I
another
could go
step
over
or
the
two.
chiropractic bill again, just to kind of rejuvenate the evening, Madam Chair.
Well, we have enough, I think, different ones we can take up, so we have some contrasts to make. So, okay, we will continue. And the next one I have is the DHS Healthcare Administration bill, and that's an informational hearing on language 06082. And Christy Graum is here to talk about this bill and give us an overview. So, Ms. Graum, when you're ready.
Thank you, Madam Chair. For the record, my name is Christy Graham with the Department of Human Services. Good to be here this evening, and thank you, members, for giving us a bit of time to get you familiarized with this bill language. I think it was actually introduced today, perhaps. All right, so this is the DHS Healthcare Administration Policy Bill, as Chair Wiklund mentioned. There are 5 main components to the bill. There is a summary in your packets as well as a bill index for you to follow along. I'll just work from the summary and identify what sections the changes are in so that you can take a look at those and let me know if you have any questions following the presentation. So the first bucket of main changes is related to Minnesota Care, technical, primarily technical, and some of its federal conformity. So one of the pieces of this proposal, and this is in sections 15 and 16 of the bill. So the first piece of this proposal is related to the final rule on Medicaid program streamlining, and it's also applicable to the basic health program, the BHP. And that was a rule that was published in April of 2024. States had, I think, about a year to come into compliance with that requirement. So DHS has now come into compliance with this specific BHP requirement. But the policy change effectively removed a requirement for Minnesota Care enrollees to pay a past due grace month premium as a condition of re-enrolling in the program. So this changes in section 16, you can see, and this is just conforming with federal rule to be able to implement that change fully. And then the next two parts of this proposal are technical in nature. So the first one is updating an incorrect cross-reference. So in Minnesota Statute 256L.05, the Minnesota Care Statute, there's an error where the current law is pointing to the wrong type of enrollees who are exempt from paying a premium. So this just redirects it to the correct subdivisions. And then lastly, in this bucket of proposals, there is an update to clarify that the coverage for the Minnesota Care Program is dependent upon a premium payment. So that's the change in section 16 that changes the word eligibility to coverage. Moving to another change related to the MA for Employed Persons with Disabilities, or MAEPD program. So folks here probably know this is a work incentive program that helps people on MA, people to maintain coverage on MA who are employed and have a disability, a certified disability. So an important program that we operate here at the Department of Human Services. And right now, statute authorizes us to deny or terminate coverage for an enrollee when they don't pay their monthly premium unless they demonstrate a good cause exemption. And that's defined in statute, and DHS makes that determination based on the definition. But one of the issues we've been encountering is that we regularly get requests from enrollees to retroactively grant good cause exemptions, and they're effectively asking us to refund them for their payment. And this isn't something that we believe was the intent of the law, so we're just clarifying that in this section that that's not allowable, that we won't be refunding payments for retroactively. And that's in section 10. Sorry if I didn't say that at the outset. Moving to section 17 of the bill, this is related to extension of a DHS legislative report related to long-acting injectables. So right now, we are administering a pilot program. This was required by the legislature. It was part of the priority admission panel recommendations that would require us to reimburse counties and tribes for long-acting injectable antipsychotic medications to people that are in county correctional institutions. So we are in the process of administering that pilot. And certainly happy to give you all updates on it, but it's an important activity to make sure, to find ways to better support people to, regain competencies so they can stand trial, or to transfer them to a more appropriate setting, which may be state-operated facilities or maybe community programs if their mental health is stabilized. So right now, we're required to provide a summary report by December of 2025, so this past December, but the pilot is still ongoing. So this would be a proposal to extend the report requirement out to November of 2026, so that the pilot would end at the end of July, and then we would have 3 months to analyze the data and provide quantitative and qualitative recommendations and information to the legislature related to that pilot. Moving to section 11. This is related to physician oversight in clinics. So this proposal removes requirements in law that conflict with newly adopted clinical service standards that CMS is requiring. So right now, our statute related to physician oversight in outpatient clinics is a higher standard than what the federal regulations require. And this is important as it relates to tribes and the what's known as the Medicaid Four Walls policy. So there's been ongoing guidance and discussion at the federal level about this policy dating back to, I want to say, maybe as far back as to 2017. And tribal nations have been working with CMS to make sure that there are some changes to acknowledge the authority of tribal providers that render services outside of the four walls of a clinic. So federal law has been amended to say that this is allowable, that tribes can get the encounter payment in those settings, outside of the four-wall clinic. And this final change to kind of conform, to bring everything all together related to the four walls policy would just clarify that a physician, that the services have to be under the direction of a licensed physician. So this is just updating state law to conform with that new federal requirement. There was some changes last session, repealing a rule to this effect in the Human Services Policy Bill, I believe. And then the last change in this bill is quite simple, but it actually looks like the most language because it also, we also brought in a recodification that the nonpartisan staff in this body and the other body, as well as I believe the revisor's office have worked on. So the main change in this section is just related to provider enrollment. And the change that we're making that's substantive is in section 7, but overall, sections 1 through 9 are related to this because the recodification touches on the section that we were amending, which would give us explicit authority to disenroll Medicaid providers if the provider hasn't billed DHS in the past 12 months. That's something that we've already done administratively, but we did want to make sure that we've got that codified into statute. So last October, we did begin to disenroll providers that hadn't billed in a long period of time. And it's a program integrity measure just to make sure that we're keeping our books clean. If there was, a bad apple that maybe we disenrolled and then they had another entity enrolled that hadn't billed in a period of time, this would sort of prevent that kind of practice where someone was trying to exploit the system. So I will stop there, Madam Chair, and take any questions.
Members, do you have any questions about this language? Senator Utke.
Thank you, Madam Chair. And I'll start out with not a question, but I do have the A2 amendment.
Yeah, so Senator Utke has prepared, there's an A2 amendment, and you want to talk about it tonight, and then we'll, if we choose to, bring it up again, then we'll actually adopt it or talk about adopting it. But do you want to present your amendment, and then there's a testifier?
Sure. Members, the A2 amendment, and I believe I did see it in the packet of stuff we got here tonight too, so you got the language. But this refers to CARMA, which is county-based, it involves the county-based purchasing. And as it was given to me, it was stated that this was just technical, coming from the department, but I understand maybe the department may have a little variation of that comment, so I will go one line further. And what this does, there was a lawsuit between the department and our county-based purchasing, and the courts ruled, and this amendment aligns us with what the courts came up with. So it is just kind of that technical movement. But again, it fulfills what we all learned this last year through the court challenge, and should align us with between the counties and the department. But I don't know if the department or any comment, or we got it pretty well covered with that.
Ms. Grom?
Madam Chair, Senator Utke, we don't have a position on the amendment.
You don't have a position, okay?
Should we have the testifier speak to it as well, or is he?
I think at this point, we do have a testifier, but we probably don't need it because, number one, we're going to bring this up and pass it at another committee hearing, but it does sound like, they don't have a comment. It's acceptable. I mean, it's where we stand today because of the court ruling. So I'm satisfied with it at that rate, but if you'd like more, we could, a testifier, I believe, is online, if you'd like to hear from him.
I'm just trying to, if he had additional information, otherwise I'll defer to what you.
Mr. Gottwald is with us. I mean, if he would like to weigh in, or if he's just comfortable with what's been.
Mr. Gottwald, do you have additional comments you'd like to make regarding this amendment?
Madam Chair, committee members, thank you. And thank you to Senator Utke and to Ms. Grom. Nothing really more to add to what Senator Ecke said. We did work on this language with the Department of Human Services, including Matt Spahn, John Connolly, and others. So as Senator Ecke indicated, it's meant to align us with what has already been determined for county-based purchasing. In order to do CARMA, you have to be part of county-based purchasing, so it made sense to align the language. The language that was originally in the bill was something we agreed to before that court ruling came down, and so it made sense to do this. We've been talking about this language for a couple of months now and have arrived at this language now that you have before you. And so we'd look forward to your positive support for it.
Thank you. Members, any questions about the amendment? Okay, seeing none right now. If you do have questions, please speak with Senator Utke. Members, any questions or comments about the bill? Senator Abeler.
Well, just two, and thanks for the work, and thanks for the, our DHS staff works like day and night, and so I just want to commend them they get tired, but they're tireless. On page 9, there's provider enrollment and categorical risk levels. So I'm trying to figure out what providers are here compared to the OIG group. These are more clinical places. I saw CFSS was listed somewhere. But designating providers limited risk, moderate risk, and high risk, this would be for fraud. But is this going to relate to clinics as well? Is there going to be, or can you just describe, I understand the idea, but can you describe it a little bit, what you're planning?
Ms. Graham?
Yeah, Madam Chair, Senator Abeler, just to clarify, this is actually recodified language, so it looks like it's new here, but it's actually existing in other sections of law. Council can confirm that and correct me if I'm wrong. But yes, the commissioner, there are federal criteria, and some providers, I believe, are required to be in a certain risk level, but under, Medicaid federal law, we have the authority to identify other providers depending on, their propensity. And it's not necessarily, it's a bad service or anything. It could be like, there was a big spike in a certain program, and so we just want to keep an extra eye on it. But it's not a reflection of the
But
of
Madam
the
Chair,
people.
this isn't medical, like the Mayo Clinic's not going to be high risk or something. This is more like those 13 categories, or is this medical clinics? They're a little shady. You're going to make them. I mean, is that a possibility as well?
Ms. Graham?
Madam Chair, Senator Abeler, we have not identified outpatient or hospital services as high risk. I can get back to you to determine, let you know if they're limited. I would guess that they're limited, but I can confirm that with you.
That's fine. And then my other question on page 10, line 11, the surety bond thing. Does this extend it to more providers than are having a surety bond now? I know we worked on a couple little recuperative care and some other stuff, but is this not expanding it to the 13 categories or others?
Ms. Graham?
Madam Chair, Senator Abeler, that's a good question. This is also part of the recodified language, so nothing has changed here. So we are not expanding it to more providers and are currently subject to surety bonds.
All right.
But happy to work. I know there's ideas in that vein, and happy to work with you on them.
And that's fine. And just my final thing, it seems as we work on all this that there are some providers who are just like the, Mother Teresa quality, highly ethical, devoted. And going forward, it seems like there could be a way where some of these providers could be given like a TSA kind of a pre-screening pass. They've been around for their legacy providers, and no real complaints, and any complaints they make are just some billing error or something. Just a thought going forward, and so that way the OIG and whoever else, Health Administration, whoever can really focus on the ones that are newer and the ones that are a little more sketchy. So that's all I have, Madam Chair. Thank you.
Thank you. Thank you. Senator Utke.
Thank you, Madam Chair. And just a little follow-up back on Section 10, when you were talking about the grant exceptions and it being retroactive and such, and now it's clarifying that doesn't take place. But my question was, did we experience a lot of that prior, or is it something that's kind of small and a nuisance?
Ms. Graham?
Madam Chair, Senator Aki, enough that we have a policy bill to clarify it in law. I don't have the specific magnitude, but I do know that there were a number of these that went to appeals, which of course takes time at the department, and you know, the appeal affirmed that no, the department should not refund retroactively, so we thought it would just cut down on that if we were explicit about it in state law.
Okay.
Senator?
Thank you, Madam Chair. This clarity will help.
Yeah.
You've drawn a line in the sand so that you got an answer for them, so great, thank you.
Yeah.
Any other questions or comments? Okay, seeing none. Thank you, Ms. Graham, for the presentation tonight.
Thank you, Madam Chair, members.
And next, we will move to an informational discussion about the DHS Behavioral Health Administration Bill. And Senator Boldon, are you going to discuss that? Or you can just...
We can present it.
Oh, okay. We'll just switch to the appropriate legislative director. And members, this is the 26-06081. Welcome to the committee, and if you can state your name and begin your testimony.
Hello, Chair Wiklund, members. My name is Gina Savage, and I am the Director of Legislation and External Affairs for the Behavioral Health Administration at DHS. I will walk you through each of the sections of the bills and then explain the proposed changes. We do have an author's amendment that I believe you have in your packets. And then when those changes are, when the changes in the amendment are, I will mention those as I do my walkthrough. So first up, Section 1 and Section 26 are changes that we are proposing as part of our mental health emergency statute cleanup. Section 1 reintroduces language that clarifies that emergency services providers cannot delay or deny timely provision of emergency services based on the client's payer source. This language was unintentionally removed last session, and because of the importance, we are proposing to reintroduce that language. Section 26 is also a cleanup from the similar bill. There was legislation, that legislation also clarified that Minnesota Care enrollees who receive these emergency services are not subject to cost sharing when those mobile services are provided. That statute specifically, mobile crisis has three parts: crisis intervention, crisis stabilization, and crisis assessment. The language specifically mentions crisis intervention and crisis assessment, but that crisis stabilization phase was not included. This proposal is not a change. All three phases of mobile crisis are currently exempt from cost sharing under Minnesota Care, but we thought this was important to highlight that all three phases of mobile crisis are exempt for clarity's sake. Sections 2, 3, 4, and 7 are changes related to our peer recovery support services cleanup. This proposal cleans up statutes after a significant revision of the peer recovery support in 2024. That legislation resulted in a new statutory framework and enhanced program standards, and then these sections are just making conforming changes. So sections 2 and 3 are updating citations just to refer to the appropriate peer recovery support statute, and then sections 4 and section 7 strike language that limits supervision of peer recovery support peers to alcohol and drug counselors only. Part of that 2024 legislation expanded supervision requirements to include mental health professionals. So we would be striking these language that limits that for consistency. Section 5 and Section 11 are related to our tobacco education proposal. Right now, behavioral health programs are required to screen for mental health and substance use disorder history, which does include tobacco use, but that is routinely underassessed. So Section 5 explicitly requires that licensed SUD facilities provide that tobacco and nicotine educational material to a client upon admission. And then Section 11 requires licensed mental health providers to assess tobacco use disorder upon admission, and then also apply the tobacco use disorder diagnosis if they meet those criteria. There is a change in the amendment that also adds a requirement in 245G that SUD and mental health providers have to document that the tobacco and nicotine educational material was provided. Section 6 makes changes to our treatment coordination education requirements. Legislation last year changed the education requirement from a bachelor's degree to a high school diploma, but that existing language around requiring a bachelor's degree was left in statute. Just to avoid confusion, this proposal would just remove that bachelor's degree requirement. Section 8, 21, and 22 are technical cleanup changes related to our Children's Therapeutic Services and Supports, also known as CTSS. Section 8 and Section 21 delete references to the individual behavior plan, which is an outdated term that is no longer used. Section 22 aligns requirements for CTS providers. Right now, the CTSS statute requires that providers have to review and update their clinical policies and procedures every 3 years, while the licensing statute requires that same process every 2 years. So this proposal would update that CTSS statute to align the requirements at 2 years. Sections 9 and 10 are changes to our mental health professional affiliation and supervisor limits. Section 9 creates limits for mental health professionals around affiliated provider agencies and supervision. While mental health professionals are responsible for training and supervising agency staff, as well as the services that they provide, there is currently no limit on the number of provider organizations that a mental health professional can be affiliated with, nor are there limits on the number of staff that a mental health professional can supervise. Concerns have arisen regarding the number of provider organizations that mental health professionals are affiliated with and the number of supervisees. To strengthen the program integrity and ensure quality supervision of these services, limits are needed. This change would set the affiliation limits at 10 provider organizations and set supervision to no more than 20 direct care or clinical staff. Section 10 requires that mental health professionals approve and sign progress notes. Current statute requires that progress notes and requires a progress note and a signature each time a staff member delivers a mental health service, but it doesn't say who is required to sign that note. As a result, our mental health professionals are often reviewing these notes, but are not formally signing or approving them. So this section would require physical, dated signature, and credentials on all progress notes. Sections 12, 13, 15, 19, 20, and 27 involve cleanup and codification related to our 1115 substance use disorder demonstration waiver. In 2019, Minnesota received approval for our 1115 SUD Medicaid waiver to improve access to SUD treatment. One of the requirements for this was implementing the American Society of Addiction Medicine, ASAM, levels of care. These policy changes have now been fully incorporated into Minnesota statute and apply to most SUD providers. As a result, this proposal would remove outdated language, update statutory references, and consolidate the remaining sections for clarity and consistency. Specifically, Section 12 strikes the requirement for utilization review for SUD treatment placements, which term became outdated following the implementation of direct access. Section 13 codifies that requirement for SUD providers to submit to a utilization review for up to 10% of all MA and behavioral health fund claims. Section 13 was also affected by the amendment. That language around peer recovery services in Clause B was, the language around peer recovery support services was stricken from Clause A, just to clarify that that utilization management requirement applies to those SUD services identified, not just peer recovery support services. Additionally, that peer recovery support language in Clause B is going to be moved to the appropriate peer recovery support statute. Section 15 clarifies that services not provided in accordance with these utilization management requirements are subject to monetary recovery. Section 19 and Section 20 consolidate the remainder of the substance use disorder waiver language. This language retains the requirements for our SUD providers to certify their ASAM levels of care in 254B19, which is where we've codified those requirements, as well as retains certain exemptions for our tribal programs and residential treatment programs that provide a specific level of care. And then Section 27 repeals those outdated subdivisions of the waiver and that are no longer in use or have been consolidated into other sections. Section 14 is a clarification of our peer recovery support statute that just specifically identifies that tribally licensed programs are eligible vendors of peer recovery support services. They can and currently do provide these services as permitted by our state plan, but they are not included in the statute, so this proposal would add them for clarity. Section 16 and Section 17 are changes to the advanced care directive requirement in mobile crisis. So right now, mobile crisis teams are required to develop a advanced care directive while doing crisis intervention. Recent SAMHSA best practices have recommended that discussion about end-of-life care and some of those discussion topics are not, that crisis intervention stage is not an appropriate time to have those complex and stressful conversations. So this proposal would move that requirement to discuss that advanced care directive from the crisis intervention stage to the crisis stabilization phase, aligning with federal best practices. Section 18 and Section 23, technical changes to our Children's Intensive Behavioral Health Services program. This program was previously called our Treatment Foster Care Services. So Section 18 is updating that language with the new Children's Intensive Behavioral Health Services program language. And Section 23 is allows a temporary service reduction to be documented in the case file. Right now, it requires temporary service reductions are required to be documented in the treatment plan, which is consuming and formal process, and by documenting it in the case file, it allows flexibility for the treatment team and the family when a temporary reduction is needed and needs to be documented quickly. Sections 24 and 25 are updating requirements for our intensive rehabilitative mental health services, IRMS, psychiatric care providers. You've heard a little bit about this proposal already tonight, but we have a similar one that would, Section 24 would align the medication management requirements for IRP providers for our advanced practice registered nurse and our board-certified child and adolescent psychiatrist. Rather than currently the statute lists the providers who can do this medication management, this change would allow medication management as long as the provider is qualified to prescribe medications within the scope of their qualifications. And then Section 25 also aligns those advanced practice registered nurse and the psychiatrist qualifications for these teams by striking the requirement that a psychiatrist must be board certified as a child and adolescent psychiatrist. This change would then allow IRMS teams to have a psychiatric care provider who is credentialed to prescribe medications. This provider could be an advanced practice registered nurse or a board certified psychiatrist, but they both would now have the same requirement for clinical experience and qualifications. Lastly, this is also from the amendment. This isn't in your language, but the recovery community organizations are currently required to obtain certification from the Minnesota Alliance of Recovery Community Organizations, also known as MARCO, by June 2027. MARCO certification establishes consistent statewide standards, and these standards strengthen program integrity for services that have been designated as high risk. And this proposal would move the certification timeline from June 30th, 2027 forward by 1 year to June 30th, 2026. I tried to be quick and succinct, but I'm happy to answer any questions.
Members, do you have any questions about Senator Abeler?
Well, I was just appreciate all your work, and I hope that the people that live in this Nitch can help me understand if there's any snags with this, but it seems like you're pretty reasonable. But you talked about Marco. I just remember it just brought back fond memories of great debates about a very parochial organization. Has it become more statesman-like compared to being what we had trouble with some years ago? Do you understand my question?
I do, yes. There was Chair Wiklund, Senator Abeler.
Ms. Savage.
I do understand the question. My understanding is several years ago, there was a national organization that was certifying these recovery organizations. There was a recent change to the Minnesota Alliance of Recovery Community Organizations. I'm not sure how many years ago, but my understanding is it's a much more friendly and collaborative group, and that we have worked with them on this proposal, and they're supportive of moving that certification.
Well, thanks. And just
Senator
finally, if they're watching, they'll remember that this was a problem because they were quite parochial and biased, and there was a lot of complaints. So if it's working well, then I'm happy to hear that. I've lost touch of the topic. I think the last time we talked about it was, I think when I held the gavel or something. So Ms. Grom, did you want to say something?
Sure.
Ms. Grom.
Madam Chair, Senator Aber, just because I was around, and this isn't actually in Senator Wiklund's jurisdiction, so I will be brief.
Oh.
But the National Organization Association for Recovery Community Organizations, I know there were issues around them not approving certain entities to do practice and to do business in Minnesota in the Medicaid space. And one of those entities had extreme fraud issues.
Yeah.
So we have not had the experience that they were unfriendly or parochial, but I acknowledge that was the experience of others. But yes, they are not part of how we're certifying recovery community organizations anymore.
I just remember this one little
Senator
tribal
Abeler.
place. So anyway, that's all good, Madam Chair. Thanks.
All right. Any other questions, comments? No? Well, thank you. Thank you for going through that. And if people think of questions, please let the agency know. Next, we will go to the DHS Housing Agency Bill, and that is 26-06083. And Lorna Schmidt is here to discuss and go over this proposal. Welcome to the committee. If you can state your name for the record and begin.
Thank you, Chair Wiklund and members of the committee. My name is Lorna Schmidt, and I'm the Legislative Director for the DHS Homelessness, Housing, and Support Services Administration, here to walk you through the last of our policy bills for the evening, and will do my best to be brief while informative. We have both a summary and a bill index in your packet. I'll walk through the summary in order and reference the sections that it applies to help you follow along. And I'll note that there are 6 overarching proposals that are included within this package. The first is found in Section 1, is specific to the Projects for Assistance in Transition from Homelessness, or PATH program. This is a technical correction that simply aligns eligible grant activities with the stated purpose of the program. The program was established a few years ago to prevent and end homelessness for people with serious mental illness or occurring substance use disorder, but was recently expanded to also serve individuals who had a substance use disorder absent a co-occurring mental illness. When that happened, they simply missed adding the reference in allowable grant activities, so this is just correcting for that, does not otherwise make any changes to the program. The second proposal, found in Section 2, is related to the Housing with Support for Adults with Serious Mental Illness program. This expands eligibility and allows individuals with substance use disorder diagnosis to qualify for services absent an identified co-occurring mental illness. This is really just recognizing that discerning the behavioral health needs of individuals who are experiencing housing instability can take time, and people presenting with an SUD may have underlying serious mental health needs that just need more time to identify. So this is all about removing a barrier to access for individuals requesting services, but also supporting a more integrated, person-centered behavioral health approach. The next proposal is related to economic assistance program reforms and can be found in sections 3, 5, and 8. This is about increasing program uniformity and removing outdated, non-person-centered language in the Minnesota Supplemental Aid and General Assistance programs. More specifically, it's looking to extend the period during which MSA applicants must apply for other benefits from 30 days to 90 days. This would align with other state cash assistance programs like General Assistance and MFIP. And it also eliminates language requiring mandatory vendor payment of general assistance benefits for individuals with substance use disorder. Right now, individuals with substance use disorder are the only individuals that are required to use vendor payments, and what we hear from counties and providers is that is administratively burdensome, but also really difficult to implement equitably because it makes staff take assumptions about an individual's substance use upon applying. The next proposal is related to emergency general assistance and can be found in Section 4. This is responsive to recommendations from the 2023 Work Group for Expediting Rental Assistance and requires county and tribal nations to report their emergency general assistance or EGA policies to DHS for centralized publication. EGA is formula-based funding that's distributed statewide, but the counties and tribes that administer it have the ability to set their own rules, and that leads to different requirements for individuals who are seeking services. Goal here is really just to make sure that we have more transparency, accessibility, so that individuals who are seeking assistance know how to pursue it, regardless of where they live. Next, Section 6 is a proposal specific to housing support. This adds new requirements for agencies to develop, make available, and report on the processes by which they review and approve housing support agreements with providers. This was really prompted by a lot of conversations with advocates, partners, legislators about concerns regarding local discretion and the lack of transparency for entering into housing support agreements, but also recognizing concerns regarding local need and capacity to administer those agreements. This is very much a first step that's intended to gather more information so that we can continue those conversations and make informed decisions about future reforms that might be needed to support individuals and providers throughout the network. And finally, Section 7 and 8 are a proposal related to repealing the Homeless Youth Act and shelter-linked mental health legislative reports. These are biennial reports that have been conducted for a number of years, but since they were initially established, we have a number of other state and national data sources that have become available, including the Minnesota Homeless Study, that have really become more current, up-to-date resources for information. So this is more an administrative efficiency, saving state resources, avoiding duplication, and recognizing that there are other ways that we can share information on the grantees. That, Chair Wiklund and members, is the policy bill. I'm happy to answer any questions.
Great, thank you. Members, any questions about this language? I don't see any questions or comments. Thank you for presenting this. We will get these bills, or these last several informational language overviews, and once they're introduced, and we will be able to have more discussions about the language in committee. And I think that's... And as a reward for making it to the end tonight, we have cookies made by Lisa Timian. So Lisa continues her tradition, so thank you to her. Members, seeing no other business before us, we are adjourned.